Well, as we heard today, especially in our point-counterpoint session, the inconsistent quality of MRA in the community. And despite the fact that we have a room full of experts, that's not what typically happens in the community. So we were asked to start an SMRA protocol committee by Michael Markle. And in addition to myself, Giles, Elizabeth, and Peter are on the committee, and we've been meeting between the two sessions now with multiple Zoom conference calls over the past year. And what we're going to do here today is kind of go through some of our recommendations and ask specifically for your guys' help. We decided that we're going to continue the clinical challenges from last year. We'll present some results from that. And what we also did was design and implement a new SMRA survey. And some of you have answered it. And one of the things we're going to be really asking you guys to do is to, if you haven't had a chance to go online and answer it, and you had an email blast a while back about how to address that. It's basically surveymonkey.com/R, and then it's like /carotid MRA, thoracic MRA, and renal MRA. And I may ask Joanne to send that blast out again tonight so you'll have it right there on your link. But what we want to do is to understand where there is controversy in the clinical protocols. The other part that we had decided was these clinical protocols for wide to be able to be used in multiple centers is it has to be able to be run on all manufacturers at 1.5 and 3T without any specialized sequences or specialized hardware. And so our goal is we're going to take the feedback that we get here and continue introducing these protocols and have them available on our page. So what we've done is we've introduced preliminary recommended protocols. I'm going to describe neck. We'll go on and describe thoracic and renal. We're going to give just a short introduction. Then we're going to mainly ask for you guys to give us feedback on a couple of areas that our survey has identified as controversial areas. And Peter is going to take notes so everybody in the committee is actively involved. What we want to then do is take that feedback and go and make our first generation of clinical, widely available MRA protocols available on our website, and then we're going to base on our website the ability for users to then give us feedback on what's working and what's not. And so in this iterative approach, we hope through crowdsourcing and experts from like yourselves to give us updates on how we can do to improve the protocol. And again, these are robust MRA protocols. In addition to making protocols available, we felt that was only part of the answer. Another very important part are tips and tricks about how to get consistently good image quality. And then what we're going to do is each of us are going to split into the three main areas that we've identified and invite other interested SMRA members to be part of a writing committee. Basically what we're envisioning is a how I do it kind of paper with the tips and tricks, with references to our webpage, with downloadable protocols that can be immediately uploaded without any operator error in typing them in. And the hope is that kind of combination of tips and tricks and active protocols should help to improve the image quality in the community that we heard was a problem today. And eventually we want to produce how-to videos to be available on our webpage as well. So with that as introduction, I'm just going to kind of kick off the next section. I think this area has been probably fairly well worked out, again with the caveat that it has to be available. Some of the interesting techniques we heard about today, like HISS, we haven't allowed because we want it to be vendor neutral. So we're doing a combination of 2D and 3D time of flight, some sort of black blood imaging, and where we found the most controversy was discussing single pass contrast enhanced MRA. What's the appropriate resolution that we as a community are going to recommend at 1.5 and 3 Tesla. What's the best way to achieve the gadolinium bolus arrival, to know what it is going to be, and how much contrast should we use at the various field strengths, and should we dilute it? So one of the first things we looked at, and we asked the people who responded to tell us what is the resolution that they routinely recommend at 1.5 and 3T. So survey says that 60% at 1.5 Tesla recommend an isotropic 1 millimeter resolution. This other was a sub-millimeter resolution, so 40% recommended sub-millimeter in plane and 1 millimeter or better through plane resolution at 1.5 for their contrast MRA. At 3T, that reversed, and the majority recommended sub-millimeter resolution, and 40% were using 1 millimeter resolution. So I want to stop there and ask a question to the audience and just kind of shout it out. What does the audience feel, because this was only a limited response, what does the audience feel is the appropriate resolution for 1.5 Tesla? This is first pass contrast MRA, not the best you've ever done in a graduate student who was thin and held still, but in your cardiac patient who's robust and a big thick neck. What is the resolution? How many in the audience think we should stick to just 1 millimeter isotropic resolution? Okay, 1, 2, 3, 4, 5, 6, 7. So 7. Okay, who thinks that we should go for resolution higher than that at 1.5 Tesla? 1, 2, 3, 4, 5, 6, 7. Okay, so that's kind of an interesting area right there. So I think what we're going to have to do, and what I'd like to do with the people who are interested, and if you're interested in being involved in the how I do it and kind of finalizing carotid MRA protocols, come and talk to me after this or during the rest of the meeting. I'll take everybody's name and we'll set that up, because that pretty much reflects what the survey had said. So that's interesting. What about at 3 Tesla? Who thinks we should stick at 1 millimeter resolution isotropic? Who feels that we should go to something of higher resolution than 1 millimeter isotropic? Okay, that's virtually everybody. Call it 12. So again, the specifics of that I think will be interesting, and we'll work them out. Now, the next one, what's the best way to time your gadolinium bolus? Survey says, so 60% do bolus tracking, 40% do some type of timing run, either a single slice or the more modern time resolve 3D. So again, here in the audience, for timing, this is either 1.5 or 3T, who likes doing the bolus tracking technique? 1, 2, 3, 4, 1, 2, 5, 6, 7, 8, 9, 10. 10. Okay. Who likes doing some form of a timing bolus? Okay, so a strong preference. For those who voted for bolus tracking, how often do you have poor quality? Either they timed too early because they mistook it for swallowing, or they waited too long? How often is just kind of shout out? Does that happen much in your practice, or do you think your techs are good enough with bolus tracking? Pretty rare. Pretty rare. Pretty good? All right. So that seems to be less of a controversial area, so I think that will be easier to write. The last one, how much contrast and do you dilute at 3 Tesla? Survey says everybody that answered the question, and realize that's only 5 people, which is why we need you guys to answer more, said that they did weight-based dosing. So in other words, no one did less than single dose. And only one person diluted. 80%, sorry, 2. So 60%, no, sorry, everybody injected at 2 ml a second, and a slide I won't show you, I think is diluting, I may show it to you. So how many here do, just give a weight-based, a single dose for contrast-enhanced elliptocentric at 3T? How many people? Okay. 6, 7. Okay, not everybody's answering, but okay, 8. 8. And does anybody do less than single dose at 3T? Okay, so that's interesting. So basically no one here in the room, this group of experts, has adopted what UCLA has published a few years ago about that they could successfully get down to like 3/4 of a dose of 0.7 at 3T, making use of the higher contrast denoise. So that's interesting. We'll have to, that I would really like to talk about. Okay, and then here was the question for diluting. There was just 80% do not dilute at 3T, yet they're still injecting at 2 ml a second. So the definite potential, we've heard this presented previously, that we can get unwanted T2 star effect and decrease our signal intensity on our first pass contrast MRA. Does anybody in the room dilute at 3T? 1, 2. All right.
Can I just make a comment, Kevin?
Please. I actually want you guys yelling at me. Yes. Preferably commenting, but yes.
Right. I mean, this is, yeah, I'm not going to yell at you, Kevin.
That's no
Kevin,
problem.
you got it wrong. There's an important connection that I've talked about for many years about resolution and contrast injection. And I think carotid is where it makes the most, where it's the most important. Because they tend to be, if you do a high resolution first pass, they tend to be 20, 30, 40 second scans. And people injecting Gatavist 10 mLs at 2 mLs per second or something is a 5-second injection. And then you're dialing into your machine, I want 0.7 millimeter resolution, but if you look at the effects of what that bolus is doing over time, you're actually taking that resolution back away from yourself in a pretty significant way through blurring, because the contrast isn't there. It's actually almost amazing, though, that the tail of gadolinium contrast is so high that the effect isn't as bad as you might think, but it's definitely there, and you're definitely shooting yourself in the foot with T2 star effects A and B with some blurring. So
Yep.
so that's why I emphatically dilute and try to inject for something pretty close to on the order of how long the scan is for all of my MRA.
Yep.
And I'll talk about that a little bit more on Friday, but that's just an important, I think it's an important thing for us to realize. Because you don't get the resolution that you think you're getting by just tweaking up the numbers.
Yep.
If
Because of point spread function and the blurring that you're getting because of the different T1 over our time. And different manufacturers are different. Different manufacturer A, you might be able to get the study done in 20 seconds. Manufacturers B and C, typically, most of us, I think, here in the room are doing 40 seconds, maybe even 50 seconds. So that, I think, will be another interesting topic. So for carotids, I felt things were pretty well worked out. We had written a protocol previously, and it's published. It's available on our webpage. As you can tell, this was from 2012. And so one of the goals I want to do is to now update that. One of the important things is once you provide something on a web page, you need to constantly be reinventing the wheel and taking advantage of newer information, such as the differential signal intensity effect and the unwanted blurring of the point spread function. So of all the areas that we're going to discuss today, I think this is the one that's pretty close to being mature. And yet I've been at a couple different major medical centers, and that wasn't being well watched. And very importantly, I got a manufacturer A magnet recently delivered to our institution, and the protocol that was built into it was absolutely terrible. And the image quality that I got from it was not adequate. So the more that we can provide this kind of information, make it easily downloadable, and my senior apps person who came didn't know how to do it. I had to give him the paper and sit and watch him and call an expert from that manufacturer with that manufacturer's experience to get the protocols to be acceptable. And so that's the kind of thing that we hope our protocol committee can help do, and we're going to kind of continue to reach out, and we're going to go on now.
Can I add another tip and trick, though, since I held up my hand to say that...
Sorry, I missed you.
That I held up my hand to say that we do bolus tracking and that we're quite good at it, but I would say that we do it transverse at the arch, because, again, a lot of our, what you call technologists, or our radiographers, they rotate between CT and MR, and they're used to bolus tracking in a transverse plane on the arch. They're quite used to that. And some of them got confused if they did coronal, and if they saw GAD shooting up a jugular vein when it's being infused, they thought that was it going up the carotids, and they timed too early. So I think it's important to, I personally would recommend that you do transverse timing at the arch rather than coronal. But anyone in the room disagree with me? But that's our own experience.
I guess it depends. Our technologists, radiographers are MR and MRA and they're used to timing with. Thank you. They're used to timing for iliacs and various other things, and they're used to coronal or coronal oblique. So I think it depends really, but I get that if you've got people who, I mean, one of our issues is that they rotate between all our different manufacturers and scanners because we've got a variety, and that causes challenges, but I think CTMR, that is a very valid point.
I just want to throw out two other...
And one more question. How much saline do you use to push the bolus? I use 30 ml.
Mm-hmm. Excellent point. That's another tips and tricks. Right. The techs want to do 20, and that's barely enough to get it from here to here. Yes, exactly. Great point.
Just two more provocative things. Just
yes.
One, the issue of time resolved we didn't really talk about. Time resolved imaging. Does anybody incorporate that into their protocol for any reason? And then two, my other question is non-gadolinium, the indication when to do non-gado, when to do gado. Is non-gado enough? You know, that kind of thing, I think, is another question we just need to flesh out as well.
Yep. No, I agree. And
intracranial vessels.
Yes.
I think there is something that we should discuss is should we do and go on with time of flight, or should we go with contrast enhanced for the evaluation of intracranial carotid arteries?
Yep. Yeah, also an excellent point. Again, we just wanted to kind of get some of the discussion points, and Peter's writing all these down, and so we will invite in separate sessions where we can have a proper amount of time to sit and discuss this with anybody who's interested in the carotid section, and then we're going to do the same as move on. This is exactly what I wanted, was some ideas of how to make these robust and adequate.
Indication of 4D. Or 4D,
yep.
What would be the indication of 4D? Why would you switch between 3D to 4D for carotid?
Well, I'm actually in the minority. I guess I was the only one. I guess I didn't even raise my hand, so it's one for. I do time-resolved imaging in a test bolus fashion, originally recommended by the UCLA group, Paul Finn, and others, and I do that all the time. And I find that extremely valuable. It gives me an excellent view of the aortic arch. It gives me very interesting temporal resolution that I find very helpful. But that seems to be a minority, so I'm happy not to push that. We want things that are robust and clinically easy. Another interesting question just to throw out that Liz and I were talking about the first night is, why are we still doing 3D time of flight of the neck? If the contrast MRA is going to work. And that's part of it was because, well, that's what we used to do. And it's like, well, maybe to make things simple, what my division head made me do, and it's actually, I think, smart, is he says, just save it for post-contrast. If the timing is wrong and the image is poor, we always do a 2D time of flight just quickly to localize everything. So we've searched for tandem stenosis. And if the contrast MRA is a total bust, then do a post-contrast 3D time of flight. And what's happened, my experience is like everybody else's, that's a small number of patients that we have to do it. And that's another way to quicken, because one of the things we need to do is to decrease the number of sequences we're recommending for the general public for a basic question that's reproducible, not for our fancy things that we were just discussing that we like to discuss.
The one problem with that is that somebody then has to be competent to evaluate how well it is that the contrast has or hasn't worked.
Yep.
And that usually adds in a delay. And very often, if the sequence is actually set up to go, the few minutes it takes to do that is usually less than somebody sitting around trying to decide whether they're going to set it up or fire it. So very often just having it in the sequence, in the protocol,
Yep.
seems to be more...
Exactly, and that's one of the things I think we'll sit and discuss with the group offline, if it is just simpler to keep it on there as opposed to doing it. But just wanted to kind of introduce another controversial area. Thank you guys very much. Which one of you two are going next? Okay, Giles is going to be next, and we'll be talking about renal MRA.
If we get some slides. I don't know. Oh, here we are. Oh, that's the last one.
Okay, we're done.
That's the last one. Needs to go back to the beginning. Yeah, that gives it all away. Hey, he's doing it for me. Here we are. Good. Let's get going. So, renal MRA, these are the major things that we thought people were using it for. Potential kidney donors, we've talked about this afternoon. Hypertension, I don't think it's for everyone with hypertension, but maybe it is in places where they want to make a lot of money, but certainly where I work, it's only for those with malignant or resistant hypertension. More niche areas, renal tumour staging, particularly where there's concern about renal vein invasion that's not been shown on CT, and vascular anatomy for patients with ureteropelvic junction stenosis. Anybody would add to that list of common indications for renal MRA, renovascular MRA? Anyone in the room doing them for other reasons? Jeff's raising a hand.
Occasionally transplants.
For looking at transplants?
Yeah, for vascular problems with transplants.
Okay. I would, yeah, I mean, I do that occasionally as well, but I was thinking of something that's sort of, I don't know. Yeah, we could put that in. We can do it. It's a different kind of protocol.
Yeah, I guess it was native kidneys.
Yeah.
We can use them separate.
We can call it, we'll call this native kidneys then. Any other indications for native kidneys? Anyone doing anything for native kidneys?
I mean, part of their staging on also post-operative complications with partial nephrectomy kind of goes along with that.
Okay.
Systemic vascular complications.
I've never been referred that, but you may be.
I mean, I used to do a lot of that. Like early on in the partial nephrectomy time period.
Okay.
Now they know complications.
Oh yeah, we do a few of those follow-up of aneurysms, serial follow-up. We've got a couple of patients that we're doing that on. Yeah, we're going to note that down. Okay. So the comprehensive protocol, I've put a question mark against this. My preference is that I think a comprehensive protocol is a good idea, but maybe we could split it and simplify it into you could have a very abbreviated protocol for certain patients versus others. But these are the kind of things that I think, these are the kind of information I think we need, if possible, to get from a renal MRA examination. One of them in there hiding is very, very challenging. It's been mentioned this afternoon, which is calculi. At the moment, I don't think anybody is trying to routinely show calculi on their renal MRA. But anyone, any disagreements with any of these items of the kind of things we want to get out of a renal MRA protocol? Anything anyone would add? Anyone argue with that list? Manuela?
One question is, should we use something like furosemide to promote the excretion, to see the whole ureter?
That comes as to whether you think that you need a urogram in every MRA that we do or not. I mean, that's one of these things that might be an option. We'll come on to that. Okay. These are the survey results. I'm just going to go through a bunch of the survey results. I'm not going to tell you the N for this, so you can guess the N if you want. But in the last 10 years, is it increasing or decreasing? I was quite surprised that most people that responded to the survey says that their practice was increasing. Anybody vehemently disagree with that? Philippe? Decreasing. Decreasing.
Decreasing because of
Yeah. So yeah. So is that something that we need to get a message out there about? Maybe we'll come on to that. Okay, what proportion of renal MRA is for evaluation of hypertension? Most people would, following what you just said, say less than 25%. Does that chime with the room? What proportion of renal MRA are for live donor evaluation? I'm surprised here that we've had some people that say that none. Actually do no live renal donor evaluation, which I find surprising. I think that's a real opportunity for us to prove that MR is a good test.
Just make a comment there. I've talked to our transplant surgeons, and to them, any kind of a renal stone in a donor is a hard stop. So therefore, they need a CT. And if you're going to do it with CT, you might as well do the whole thing with CT.
Yeah.
That's their attitude.
It's bizarre because, I mean, I've been doing this for 12 years now, and I've never been asked for a CT to say, is my altruistic donor got an asymptomatic stone? Because they test all their wee-wee, and the wee-wee doesn't have any red blood cells in it. And if you don't have any red blood cells in your wee-wee, you don't have renal stones. So so I've never been asked for it, and they've transplanted lots of kidneys, and I don't know of any complications they've had by finding a stone that we didn't show them. I had one donor that we did last year that I found incidental renal stones, but they were big chuckies. They were obvious.
You find incidental stones all the time.
Yeah.
And I don't know if those patients have.
So obviously it depends upon your local transplant surgeons, but there are obviously transplant surgeons like mine that are quite happy not to get that. Okay. What proportion of renal MRA requests are for UPJ obstruction? Obviously, not very many people do this, and quite a few people say none. I answered this query and I said none because I've never been asked for it. But I suppose if you've got pediatric in your population, then it's maybe a little bit more relevant. Anybody else, any comments on UPJ obstruction? Martin, not something you do?
Not too much.
Okay. Declining renal function, again, not a common indication. I think that's reasonable because the evidence is out there for declining renal function that I think that renal artery stenosis intervention in Astral and Coral did show that intervention for declining renal function is probably not what we should be doing. The problem is that the general lay audience of the medical community has interpreted Astral and Coral as saying that renal artery stenosis doesn't matter for hypertension. But of course, you are completely ineligible to go into Astral if you had fibromuscular dysplasia, because we knew that for intervention on fibromuscular dysplasia for hypertension is good and does work, and you were ineligible to go into these trials for that. So, I think there is a message to be got out there that renal artery stenosis for malignant and resistant hypertension is still something that we should be looking for and dealing with, and that MRA has a role to play there. I don't know how we get that message out, but it's something I think we do need to talk about. Which contrast agents do you primarily use? I think we maybe messed this question up a little bit. Everybody uses ACR class 2. Obviously, the society is heavily North American biased, but ACR class 2, if you remind ourselves, is gadobenate, gadoteridol, gadoteric acid, and gadobutrol. Okay? ACR class 2 is not cyclic alone, because gadobenate is not a cyclic agent. In Europe, we are no longer allowed to use gadobenate for renal MRA. So I think we would need to tease out a little bit more about which contrast that we use, because when we put the protocols on the web, we'll need to clarify that issue. Anybody comment on that? What dosing rate? Weight-based dosing, everybody said. Rate, we discussed this for the carotids. But quite a few people are using 2 mils a second for renals. That's probably because it's a quicker acquisition than carotids, but I still think that's too fast. And we don't go above 1 mil per second. Anybody an advocate of going at 2 mils per second? Anybody would argue strongly that we should be using 2 mils per second of a contrast agent for renal? No. So I think that's a clear.
I think one of the nice things to do is to take the Paul Finn approach, and you dilute a single dose to 40. Injected it too.
You can do that, yeah.
Works nicely, and it's a routine that the techs get used to, and it's always the same.
Yeah. The only problem there is the diluting, and the diluting is a faff. The diluting is a real faff to do for the technologists. I'm not sure whether we could recommend that as a society that we should be, because it also technically, it makes it off-label if you dilute it, if you interfere
That's
with it.
the big problem. And we
So I don't think
we
we
want
can
to
do
dilute, and we were able to overcome that, but it was it's an issue if, it's on the
I mean,
radar.
the slower you
contrast.
inject, the more you are effectively diluting the bolus anyway, to some degree. The pity, again, we could talk to the manufacturers, but in my CT practice, we have pump injectors that will mix saline and contrast at the same time. Why our MR pump manufacturers can't do that, I don't know, particularly since they're the same manufacturers. That would be really nice.
Well, I've heard that's a labeling indication as well, because then the contrast agent isn't what was approved. And they bought that badly in CT, and they almost got in trouble there.
But they have done it.
They have done it, yeah.
Yeah, and I think side effects are also related to the volume of injection and to the rate of injection. So the less the volume, the less side effect you would have, and the less speed you inject, the less side effect you would have also.
So I think that's a pretty clear win for 1 mil per second at the moment. Okay. What's the minimal acceptable spatial resolution? Similar question that we asked for the carotids. Everybody said basically about 1. I think 1 has got pretty much a win. I mean, if you can go higher, I think great. But I think 1 millimeter is probably what we would recommend, 1 millimeter isotropic. Anybody any issues with that? No? Moving swiftly on. Bolus arrival time? I mean, I have an issue with this. Most people have said bolus tracking, but I think it really is a problem. And it's one of the major causes of bad renal MRA is bolus tracking, because the patients, they're hearing all that noise and they're not hearing the technician, and the technician is panicking, they're watching, and I see it over and over again. It's the thing that makes renal MRA bad. So once we switched to doing an effective timing bolus, where we know that the contrast arrives at 24 seconds and there's no gradient noise happening, and we can breathe in, breathe out, breathe in, breathe out, hold your breath, and go, then we get much better renal MRAs, much more consistent. So my preference would be to say, despite what our audience have said they do, I think we should be saying that we should be really thinking heavily and strongly about using some kind of bolus timing. As I say, I do a renal perfusion on everybody that we get perfusion information out of, so it's a double hit. But
I mean, I think if you can argue that if you combine it with some kind of functional analysis and make it worthwhile, or you combine it with time-resolved imaging or something to get the timing. I feel like if you're going to do that, you want some information and not waste time doing the timing run and calculating it. Because the text that
it's not a waste of time.
I understand,
if you get a crappy exam with the kidneys bouncing up and down.
I understand that, but for workflow reasons, and then the techs are used to doing bolus tracking.
Workflow shouldn't be the enemy of quality.
It is the enemy of us in terms of that's what we fight for. That's what that's a very legitimate issue is workflow for us. So.
Yes, Kathy?
If you do initial, even if it's a small contrast bolus, you then get contrast in the renal pelvis and into the portal vein quite often, which then obscures some of the detail.
I've been doing this for 3 years. We give 1 mil, and never a problem. And it's quite nice seeing a little bit of ureters and coming down at the same time as the MRA.
We always found that it started obscuring things, and actually with our, we tend to do the renals all in one go, and we have quite a large practice because it's a hypertension referral, but they are used to the fact that the one thing they've got to get right is the breath holding and the timing, and I think we get good images that way, and we don't have the obscuration, which was a problem.
And so these are all good topics, but we need to keep moving. And that would be exactly what I would think Giles, when he leads his section, would need to be worked out. And again, in a thoughtful, organized kind of fashion. But these are exactly what we're trying to get out, are different opinions and understanding where the controversies are that we can address.
And again, we had this bolus arrival, whether it's transverse or coronal. I say our preference is to go transverse because our CT technologists are used to it. Yes, Manuela?
I only want to focus on test bolus very, very strongly. Otherwise, you will get venous overlay in many, many cases. And I do test bolus also in patients where AV malformations are the question, and I do then not the conventional renal angio, I do the twist angio.
Sorry? Keep going.
I do the twist angio, but after timing, to have the first 3 or 4 phases of twist regarding one twist sequence, 2 or 3 seconds, to see AV malformations, feeding vessels, or also fistulas. And the excretion system for me never was a problem, never.
And you'll be giving bigger doses for a tricks, twist, whatever, than I'm using for my perfusion.
Sometimes I add the twist after the conventional angio.
Oh, okay.
Yeah, if I see in conventional angio some questionable areas, I add the twist with 4 ml.
I thought this was interesting. Some do it on inspiration, some on expiration. I'm not sure of any thing there. Older people tend to hold their breath better in expiration, but I'm not sure that there's any reason we should go for either. Anyone in the audience got a rationale for doing one or the other?
I like to do a combo. I start with end expiration, and then I do 2 back-to-back, and then I have a little space in between. Partly, it's more for like ischemia and median arcuate ligament. So I have one start expiration, then I have a little like 7 seconds.
That median arcuate ligaments for visceral, that's not for
I know,
renal.
I'm just saying, but like that's one way to do it, so they can do it back to back in case they miss the timing. It serves 2 purposes.
Yeah.
You know, expiration is more reproducible, so you start with that, and then you have a little break. Because I do 2 back to back if I never get the timing right. You know, so I always have a backup. So it's one way to get both.
But only one will
Make
go with
everyone happy. I don't know.
only one will go with the mask.
I don't necessarily. Yeah. You already lost it. If you're-
Non-contrast. So no one said never, but most people don't seem to do a lot of it. Should we be promoting non-contrast? Probably as a separate thing. What do you got something to say, Philippe?
I think we should move more and more to non-contrast.
Yeah.
I think for certain I agree. For indications like renal artery stenosis, you can start with non-contrast. The question is, you can't necessarily check every case, so how are you going to know it's diagnostic?
But the problem I see
I
with
do both.
non-contrast is, in my hands anyway, it failed often, and that means you have to recall the patient. And secondly, it doesn't have the coverage to cover down to the iliacs. There isn't robust evidence showing that we don't miss renal arteries for accessory arteries and that kind of thing. The evidence base isn't there. Yes, I can see the attraction, but at the moment I don't think we have the evidence to say that we can go to it.
And also tumor, you will miss the tumor.
Yeah. Does your institution evaluate renal function with MRI? Obviously, I must have answered this question yes. Someone else has also answered this question yes. But what about these other ones? No? Well, I think it's something we should be doing. It's extra information we can get for free.
I make the sequence, but I have nobody to keep the numbers to evaluate.
Yeah. Okay. How do you measure stenosis? I'm not sure this was a terribly relevant question. I'm not sure it's something we should necessarily give an opinion on, but
I think
the answer. This is just what people said. Depends upon the local expertise. That seems to be a lot of what happens with MRA all over the shop, no matter what we're talking about, doesn't it? I don't think it informs particularly what we put on our protocols. When do you perform MR urography? So this is something we could say that this is optional, because obviously the hypertensives, we probably don't need to do that sequence, that extra breath hold and show that. So we could put this as an option at the end of the protocol, and it is something that goes at the end if it's giving a GAD protocol. Obviously, if we're doing non-contrast, then they're going to have to drink a lot of pineapple juice. And then this is something Liz actually brought up. Do you routinely do in and out of phase imaging or a DIXON imaging for your hypertensive patients, just in case there's just in case there's an adrenal adenoma? I don't. I do look for adrenal adenomas. I want high quality imaging, so I do look at the adrenal glands in the hypertensives, but I don't routinely ask for an in and out of phase just in case there was going to be an adenoma. because I'm not sure. I mean, that it's not that uncommon, but it's uncommon enough that I'm happy that the patient would be recalled for some formal adrenal imaging if we found an adenoma.
It takes one breath hold.
It takes one breath
I think
hold.
it's worth it.
I suppose if you did your DIXON, how about post-contrast? Can you do it post-contrast? Because I do a T1 post-contrast anyway as a vibe.
I don't.
Dixon is better, then you have in and out of phase included.
And post-contrast, is that all right?
No, I never do. I've never done it. I don't have no experience characterizing post-contrast an adenoma, but you guys tell me. I don't do it. I have no experience.
Because again, I mean, it's only really for the hypertensive patients that we're interested here. So all the UPJ patients, all the renal donors and people, then you wouldn't do that. So it becomes another option.
And move on. We'll
Okay.
discuss that later.
This is the protocol that I use, and this works on an 11-year-old Avanto, and it also works on an ERA. So this, I think, is pretty robust, and this is something that I've put. I put it up last year, and I haven't changed it since last year. It gives us good pictures of the kidneys. It gives us perfusion information that we get on, as I say, it's an 11-year-old Avanto can do this. I'm sure all your magnets can do this. Probably do it better. We get really good renal MRA. We want to see the intrarenal branches against the parenchyma before the parenchyma is too enhanced. We want to see the renal veins. This is a complex one, which is retroaortic and going with the lumbar veins, just like Manuela was talking about earlier in her talk. We do a T1 post-contrast, a vibe, a FAT-SAT, in order to get renal length that we can measure accurately. It's isotropic, so we can cut it any way we want, cut it obliquely, and we can then measure the size of the kidneys. Ideally, I'd like a physicist to go in there and give me the kidney volume, but at the minute we just give a maximum length. And we get a free MRU at the end of it because we've given GAD, and we're just going to do another breath hold at the end of that. So it's pretty comprehensive, and it only takes about 20 minutes. So I think it's a pretty good protocol. Pretty much similar on Siemens, on Philips to Siemens. The only thing at the moment we haven't done on the Philips, we're still working on it, because on the Philips is a more advanced scanner. We want to do that as a volume for the perfusion, but get very similar quality images on our Philips system. And we had one submission for a non-contrast protocol from Japan. So thanks to Hideki Ota to giving this, but this is a start that we're getting more than the major manufacturers. So it'd be nice to put this on the website as a non-contrast. So thank you very much for that. Any wrap-up comments on renal? Hand on to Liz. Great.
Okay, so here I do need your help because I think there are controversies. So I do encourage you guys. I know there's many good protocols out there for thoracic, and it's pretty standard at this point. But I'll just raise some of the controversies I think about. When we thought about the indications and the potential protocols, the thoracic aneurysm is one of the mainstays to follow up and initially diagnose aneurysms. Coarctation, vasculitis, and very rarely acute aortic. I've only done like one in the acute setting for an unusual reason. And then we'll cover some of these other things that involve the upper extremity at a separate date. So most people are using, gadolinium. Very few are using ferromoxetol. Here's where I think is an interesting controversy, whether we continue. Some people use 1.5 and 2 times dose versus weight-based dosing. Do we think weight-based dosing is sufficient with the contrast agents that we have? And I don't know if anyone has any strong feelings about it now. We don't have to discuss it now, but I wonder whether we could do weight-based dosing. I would advocate for that. And again, the rate issue and whether we do it dilution. What do you think?
1 ml per second works.
Yeah, and dilution? Diluting's better. I would agree here too. And so that's something we can talk about more, and slower rate is probably better. And then resolution-wise, we were somewhere between 1 and 1.5. Isotropic voxels, of course, is preferred. Again, we can think about it 1.5 versus 3T Sorry, did someone have a? Oh, yeah, sorry, I'm sorry.
So you're talking about the thoracic or the abdominal?
Oh, sorry, I'm just thoracic aorta we're talking about.
Okay.
Although that is a point, you know, doing an aneurysm study, when do we do both? When we do the entire aorta,
Yeah.
and when do we just do the thoracic aorta?
Yeah.
But we'll just keep with thoracic for now, and that's something we can discuss,
Okay.
I think, at another point.
So you always inject?
Sorry?
You do always contrast enhance?
No, no, I'll get, yeah, no.
Okay.
This is sort of results for the survey. I'll get to that. I'm with you. So resolution-wise, we want to come to conclusion between 1 and 1.5, and we'll see if we might want to vary that by, in terms of 1.5 or 3T. Most people are bolus tracking. Some are combining time-resolved imaging. So split dose is another question. And in those cases, do you need more to increase the dose for that? Breath hold, it was sort of, everyone's breath holding, 50-50 on inspiration, expiration, so I think it's dealer's choice there. Whatever the patient can handle, I think is reasonable. And then most, of course, are not gating, they're GATO MRAs. Saggio oblique is the most common plane it's acquired in. And there's the sort of equal single pass versus split bolus approach with time resolved, and it goes back to the carotid question as well. So that's an interesting question. It may depend on indication. And then most people are doing non-con only if requested or if low GFR, but I think we see that more and more in the congenital hearts follow-up, congenital heart patients. And when you're really just looking at anatomy, non-con can be sufficient. And then there's variable use of flow analysis and phase contrast, and I think that really depends on the indication. And the question of whether we include the abdominal aorta, I didn't pose to you. So I kind of broke it down to all the potential sequences that you might use and whether you do use all of them or not. I was just trying to think about what we would break things down into, and so we can talk about this more. Talk about this more, but for a thoracic aortic aneurysm and chronic dissection, I think that's sort of a similar protocol, and perhaps one would, you can interrupt me, but I think one might use flow assessment in the initial phase, and whether you continue doing that each time is a question. And then acute aorta really is not doesn't really happen that often, and would probably be blended in with the dissection type protocol. Coarctation, I think most people feel that we'd include a flow analysis. And for vasculitis, I just had questions to people whether they're using diffusion or T2, and whether they use post-contrast gradient echo or not. And so I don't know if anyone has any, I don't want to keep you much longer, so if anyone has any strong opinions about that or wants to share their functioning protocol, please do.
I think I'd like to just say that
Yeah.
although I'm a great fan of contrast-enhanced MRA, this is one area where the majority of what I do is non-contrast, because most of my practice for thoracic is bicuspid aortic valve follow-up of enlarging aneurysms and coarctations, and in those it's critical that you can measure the root, the sinuses of Valsalva, STJ, etc., and that needs to be ECG gated, and I can't do that with contrast. So the majority of my thoracic MR practice is with non-contrast, and I only use contrast really for the vasculitis ones where we're looking at arch branch involvement and we're looking for enhancement of the aortic rim and stuff, to be honest.
Yeah, I think that is a way we might be going when we make recommendations. The only thing is if you want to look at the great vessels and so on, it can be challenging with the non-GATO, but the ECG gating and be able to look at the root, I think, is very important. So I do think there is a shift. I see it in my practice, the shift from gadolinium enhanced to non-gadolinium enhanced. Manuela?
I have a lot of patients follow up after it's comprehensive study for me.
Right. So then it comes to the question of how many protocols do we have for thoracic aorta and what your institution can tolerate. It's probably not, one size is not going to fit all there. And so I do think we have to categorize it and where we feel the common indications are. Most people are not using contrast-enhanced, gated contrast-enhanced imaging, ECG gated. I think because of the length of time or the perceived length of time with most older scanners, it's hard to get that going because the patients will have a lot of respiratory motion. So I think it's just traditionally we don't advocate for that as much, and we rely on the non-GATO to get you, even though it is feasible. If it could be faster and more out of the box, I think that would be good. Yes, please. Prince first.
So if we're talking about non-contrast 3D MRA and field strength viewpoint, so
Yes, so at 1.5 versus 3T, 3T is much more challenging, and so what are your alternatives there? And so I think that's another conversation that we need to have. And if you have any, again, tips and tricks on this, please send us your protocols and your advice, and we welcome it to try and come to some agreement on this, because I think it would be, just concluding what we were talking about, one of the things that I find, and I've gone to different institutions, there's a lot of anxiety from the techs and a lot of anxiety from clinicians, or from the radiologists when they have something, an MR vascular case, and even a CT vascular case. And I do think this can help advocate for bringing MR more into the community by giving them the tools that they need and to try and standardize. We can pick up everything apart. There's always different things you can do, but to agree on some kind of baseline that is sufficient, and then encourage innovation as well on the side, that's great. But for daily clinical practice and getting out to the community, I think this is important, and it's more important we come to some kind of bare minimum agreement, even though we know there's a continuing evolution, and we don't want to stunt creativity either. So I think with that, I think we're good, and please, if you want to get more involved, please let us know. We welcome it. Thank you.